Good afternoon, everybody. So we are on an electric train now. We don't have any engine. So I'm Ranjit Singh DHALIWAL from Nabha. I'll be starting my innings here. I come from a very small place, Nabha, a population of less than 1 lakh, surrounded by a vast rural hinterland, is connected to Delhi by just 2 trains. A saving grace is we have an international airport within 90 kilometers of Nabha, which is a better situation than all those metros, Delhi, Bangalore, Bombay, etc. This presentation, as all my presentations are dedicated to Vikram, I'll be speaking on why MSICS. Well, just for one reason, because it is a surgery for all seasons, a surgery for all reasons. Ophthalmology today is on its cutting edge. Better, not necessarily the finest equipment, in association with absolute dedication to ophthalmology to provide personalized care to even such patients, free or at a cost affordable to them, is the necessity. The aim is to provide dedicated professional care. Improvisation and indigenization brings the latest technology to the multitudes of masses of our country at a reasonable cost. A modern setup at the primary level can also boast of quality services and does not cost a fortune, I would say. So, why is manual SICS a surgery for all seasons, a surgery for all reasons? India, a land of vast disparities, presents at any given time a linear panorama from ancient couching, it's still there, to modern phaco. Manual SICS fits in at all levels, a surgery from primary to the most advanced level of patient care. Cataract surgery is no longer a simple rehabilitative procedure. It's an extremely precise refractive surgery, the goal being emetropia. It used to be emetropia, but now we are using astigmatism also to our advantage. It is an easy, provides all the advantages of a small incision with few complications. It has a hazard-free, smoother and easier learning curve, rather no learning curve for one already into ECC and implant surgery. Well, I wonder if people are learning ECC anymore. It is, in fact, a revolutionary technique ideal for teaching institutes, government tertiary centers, and wherever finance is a constraint. It has arguably the same objective and results as phacoemulsification, presumably not a single absolute contraindication. Charm of SICS is its simplicity. Repeatability we have to add on our own. It is a no additional cost option and little extra investment is required. This is the only place where we differ from the phaco people. Nucleus in management in SICS is a single step procedure. This one was around 9 mm size. And we were able to, these are two different cases. In one, we took out a cord and then rotated the lens out. The other was brought out straight away. The nucleus can be delivered with a fish hook made of 26 gauge needle and an irrigating vectis alone, or by the sandwich technique, or by the hydro or visco expression technique. Cases of cataract coexisting with most eye comorbidities have all been taken up for manual SICS at our center at one time or the other. Manual SICS is a must for a phaco surgeon for times when he has to convert phaco machine failure, posterior capsular rupture, zonular dialysis, hard black or brown cataract, or having used too much phaco energy. A phaco machine and the paraphernalia that goes with its instrumentation, sterilization, repair and replacement are a costly luxury for small clinics, though everybody is going for it now. My most controversial slide. Phaco machine out of order, the ordeal begins. Sales and marketing teams efficient, slick, and polished after-sales service department, callous, indifferent, and unreasonable. The number of WhatsApp groups fighting J&J and so many other companies are a witness to this. The less said, the better. Phaco surgery has a hazardous and steep learning curve and arguably is a time-consuming procedure for people other than the masters. Common problems faced in cataract surgery can all be tackled with manual SICS. I have listed them below. Temporal surgery can be a boon for patients like this, and a superiorly placed trabeculectomy bleb. Traumatic cataract and pre-existing defects are no contraindications. A difficult situation, a simple solution, not related to my talk. Another case of deep-set eyes with a narrow palpebral fissure. A lateral canthotomy did the wonders. Temporal approach, the advantages are the external scratch incision may be placed right on the limbus. By opting for the temporal approach, we are able to bypass the eyebrow in a deep-set eye, and the bridal rectus suture is not necessary. Irrigating fluid flows down through the lateral canthus, so no chances of backflow of the fluids. Advantages include in oblique astigmatism, this can be slightly modified. The tunnel is moved superiorly or inferiorly, placing it tangential to the steep meridian. Superiotemporal approach is also used in cases having no astigmatism. This was one of our post-op cases, 1 day post-op, 6x6 unaided. And I put up this slide just because I like this picture. And in manual SICS, the final results are arguably extremely good in the learning period, but fascinating once the technique is mastered. So that's my grandson trying to figure out what all is happening around. Thank you for your patience.